Right. Thank you for making me feel old. You said I'm a grandfather already. Anyway, I think the subject topography is very vast and it's very difficult to sum it up in 8 minutes, but I'll just try to be giving you just basic concepts. Well, corneal topography, we all know, is a measure of the shape of a surface of the cornea. Now, in today's world, measuring the shape of surface of the cornea has become very important because, as you know, in refractive surgery, basically what we are doing is we are altering the shape of the cornea. And when we want to alter the shape of the cornea correctly, it's very imperative that we know the shape of the cornea correctly in first place. So, accurate measure of the shape of the cornea assumes significance today in the era of refractive surgery. Now, it's not that only today we have started measuring the shape of cornea. We have been doing that for the past many decades, and we have been doing it by a simple procedure called keratometry. Keratometry, as you know, is a procedure with which we calculate the corneal curvature, which is again a measure of the shape of corneal surface. And that procedure gives us information about the average keratometry reading of the average curvature of the central cornea, which information was good enough for us to calculate the intraocular lens power or for other indications other than keratorefractive surgery. However, what was the drawback in keratometry? Because basically the drawback was that in keratometry we are measuring only the curvature only at 2 points. Do you have a pointer here? So only 2 points which are lying in the central 3 millimeter zone. So we measure the curvature on those 2 points, and then assuming that the central cornea is spherical, from there we use that information to calculate the curvature of the central cornea. However, we are making a big assumption there that the central cornea is spherical, which, as we know today, that it is not. It is aspherical cornea. Therefore, the reading that we obtain at 3 millimeter does not hold true for the central cornea. However, that was still good enough for us to know K reading for the purpose of IL power calculation. So, the drawbacks are that we are measuring only at 2 points. We are assuming that cornea is spherocylinder, and then we are not getting information on the central and peripheral cornea. We are getting information only on 6% of the cornea. But today, since we want to change the shape of corneal surface, we want to know the information about whole of the corneal surface, and that is done with the help of topography. As of today, we have got two main techniques of topography. One is known as placido disc topography, where we measure, which we depict by curvature maps or power maps. And the other one technique that is known as elevation maps, whereby we estimate the exact position of different corneal points in space. Now, what are these two techniques? Placido disc topography, here it is a modification of the old keratoscope. Here what we do is we project circular mires onto the cornea with a target, and the image of those mires is recorded, and after recording the image of those mires, from the image we calculate the angle of reflection at multiple points on the image, and from the angle of reflection we calculate the curvature of the cornea. So we measure curvature of cornea at multiple points which cover about 60% of the corneal surface, and from that curvature we can calculate the power of the cornea, and then we display that information in the form of color-coded maps, where to the higher curvature we give warmer color, that is red, and towards red, and to the lower curvature or the lower power we give lighter color or the cooler color like blue. And with that, by looking at the picture, we come to know that which part of the cornea are steeper and which part of the cornea are flatter. For example, in this picture, if you look at it, we find that the vertical meridian of cornea is steeper, having warmer color, and the horizontal part of cornea is flatter, having cooler color. So that's how placido disc topography helps us in identifying the shape of the corneal surface. So, by doing this procedure, we can find out whether the cornea is prolate in shape, that is the central cornea is steeper, or it is oblate in shape, as happens after refractive surgery, where the central cornea is flatter, whether it is having an oval shape, or it is having astigmatism, whether it is a symmetrical astigmatism, or it's an asymmetrical astigmatism, or whether the cornea is having total irregular corneal shape, or whether it's having any ectatic or thinning disorder. And we can also study the cornea over a period of time and see whether there are any changes occurring in the cornea as a result of any procedure we have done or because of any disease that cornea is having. However, it gives information only about the anterior surface of the cornea. Proceduralist topography on the other, sorry, all right. Now the drawbacks with this topography are that it gives information on the basis of single image that it captures, and then if that image is not captured properly, and if the patient was not looking straight or there was some angulation, the information that we'll get will be skewed and will not be correct. As was shown by Berlin, that if you in the same patient, if the patient is seeing straight, you may get a different picture. However, if you take the picture when the patient eye is not aligned properly, you can get a totally different picture, and you may misdiagnose the patient as having a keratoconus. So it's very important that in these cases that when you take the picture, patient eye is aligned extremely properly. Then again, we get information only on a limited area of the cornea, that is about 60%, because peripheral cornea doesn't get covered, and even the center 1 millimeter also doesn't get covered because there is no mire in the center. Then importantly, we do not get information on the posterior surface of the cornea in these cases, and again we do not get any information on the thickness of the cornea. However, this technique does give very good information about presence of irregular astigmatism, and it can capture the presence of irregular astigmatism very, very elegantly as compared to elevation topography. Then again, there are certain indices which I will come to later on, which can again help us in diagnosing ectatic disorders by this technology. Elevation topography, on the other hand, what it does is that it captures multiple images of the cornea, either by scanning a slit over the cornea or by other technique called rotating shift photography, and then each of the point on the cornea that is captured, that point is broken into 3 coordinates, a process called triangulation, and which gives us the position of that point in space or elevation of that point in space. And that elevation of each point then again can be color coded to give us a color coded map. Now, however, just by having a raw data of elevation of these maps does not suffice, because what we are measuring is very, very minute or subtle abnormalities on the corneal curvature. And if we take only the elevation data in the raw form, we'll find that if we convert into color coded maps, we'll not find much difference in when we get the color coded maps. Can I take 2 minutes? For example, if the patient is having keratoconus and we have a raw elevation data and we convert into a color coded map, we'll find there is not much difference between normal cornea and cornea having a steep curvature. However, if we compare this elevation data with a reference surface, or with a reference surface, so that reference surface is very close to the curvature of the test cornea, then if we subtract this curvature from the reference surface, then the information we get becomes very useful. For example, now if you compare these two surfaces with the reference surface, we find that the difference in the two cornea becomes very easily magnified and visible, and that we can get with the color coded maps in terms of a color coded picture of keratoconus. So what we actually use in this case is not a elevation map. What we use is elevation subtraction map, where the elevation data is subtracted from a reference sphere to get a good picture, to get a useful information. So advantage of elevation topography is we get multiple images. Here coaxiality is not that important. I mean, we get information not only for the anterior surface, we also get information for the posterior surface. So we can get elevation map of anterior surface and also posterior surface. Why elevation of posterior surface is important? Because as we all know that condition like keratoconus, they usually start in the posterior cornea. And it was seen in a study where a set of neglected keratoconus patients which was studied by video keratography or placido-based topography. They were labeled as cases of unilateral keratoconus. However, when the same patients were subjected to elevation topography, it was found that the 80% of the other eye, which was labeled normal with placido, it had posterior elevation. So it had posterior keratoconus. So that's the importance of posterior topography. And since it's measuring both surfaces, by subtracting the posterior from the anterior surface, one can get corneal thickness of the total corneal surface. So it gives a much more composite picture with elevation topography. The major use of topography, as we know, is in detecting actinic disorder like keratoconus. If we are using a placido-based technology, we will find in case of keratoconus either we are having an asymmetric astigmatism or inferior steepening of cone, which is very characteristic. And whenever there is doubt, it takes the help of an indices like inferior superior index or center surround index or the skewing of the radial axis, with which it can give us a definitive and objective information whether the patient is having keratoconus or not. However, if you want to have more composite information, we need to use a elevation map, which gives us information on keratoconus with four criteria. That is anterior surface elevation, posterior surface elevation, the power map or the keratometric map, and the corneal thickness. And each of these parameters can give independently and in combination can give us an idea whether the patient is having keratoconus or not. For example, if there is an anterior elevation of more than 50 micron or a posterior elevation of more than 55 micron or a corneal keratometry reading of more than 47.5 diopters or a thickness of less than 470 micron, each of these indicate presence of keratoconus. However, what happens if patient is having a subclinical keratoconus or a very low severity keratoconus, then how, and all four parameters may not be positive, then how do we decide whether patient having keratoconus or not? Then usually we go by the principle that if out of all the four maps, if only one is positive, then we do not consider it as patient having keratoconus. If two are positive, then we say the patient is suspected to have keratoconus. We still have to prove it by other means. If three or four are positive, then patient is having a definitive keratoconus. Similarly, we can also diagnose other actinic disorder. In IL power calculation, again, it's a better procedure to use than keratometry, since we want to have information on the central cornea. Again, if sometimes we have a patient with unexplained low vision, patient come to us and we do reflection, patient doesn't improve, and we want to know why it is happening. If we do a topography, we'll find the cornea is having irregular astigmatism, and that's why patient vision is not improving, and such patient will do well with contact lenses. Similarly, after refractive surgery, many times we find a patient come with visual symptoms and not improving vision with glasses, and on slit lamp examination everything is normal, but if we do a topography, we'll find that patient could be having a eccentric ablation, or there could be an irregular ablation, and previously we also used to see central island, so which all could be the reason for unsatisfactory vision, and each could be dealt accordingly. Similarly, if patient come with regression of effect after refractive surgery, we want to know whether patient having ectasia or regression. Again, with the help of this technique, we can find out whether it's a regression that is taking place or patient is going to ectasia. And lastly, again, if we want to correct post-operative astigmatism and we are doing a incisional procedure, we want to know that which hemimeridian of the meridian is more steep, where you want to give incision. So this technique helps us in knowing that out of the steep meridian, to give incision in which hemimeridian, which is the more steeper hemimeridian, so that we get maximum result. So these are the major application of topography, and I said that topography has become extremely important today for its role in refractive surgery, and all of us must know this procedure if we want to go into the field of refractive surgery. Thank you.